Good morning, good afternoon, good evening, ladies and gentlemen. Welcome to the webinar series on public health approaches for malaria elimination. And today's topic is mass drug administration for Vivax malaria. I'm Neena Valecha, a clinical pharmacologist and malariologist from India. And I served as regional advisor for malaria WHO CRO and also was in ICMR, National Institute of Malaria. Asia Pacific Malaria Elimination Network, APMEN, is a collaborative network, and the APMEN Tech Talk series focus on specific thematic areas of APMEN working groups. And APMEN comprises of national malaria programs from 22 countries and 54 partner institutions and facilitates technical exchange through its three working groups, which are surveillance and response, vector control, and Vivax working group. And Vivex working group, I would like to inform that has significantly shifted its focus from research and development to policy and effective implementation, and has been working on implementation challenges faced by different countries and also supporting them with decision making by conducting many implementation studies or supporting technically to the countries for those studies. Now, coming to today's topic, mass drug administration has had renewed attention as a strategic intervention to accelerate malaria elimination. And we know that by clearing infections at community level, MDA can reduce both incidence and prevalence in low transmission or pre elimination settings, where even a single infection or case will matter. However, success of MDA relies on several factors, and most important ones are acceptance, participation, coverage, adherence, and all those. I'm sure speakers will be talking about it today. And for Plasmodium vivax, especially if you give only chloroquine or MDA with chloroquine, this may not work because we know Vivax has liver stage parasites and chloroquine doesn't work there. So including use of radical cure medicines like tafenoquine or primaquine can be a game changer. But then there are safety issues with those medicines and which need to be addressed. So today we will be presenting the latest evidence on current WHO recommendations on MDA for Vivax malaria, and in addition, experts and researchers will share the practical experience from field, including operational hurdles to community acceptance and adherence. And our panelists today are Dr. Kim Lindblad from Switzerland, Dr. Soy Tai Ting King from Cambodia, and Dr. Ong from Thailand. Now, let me at this stage make some housekeeping announcements. The audio and video of participants will be disabled, but we encourage the comments on the chat box throughout the session and also questions in the Q&A box. And we'll try to address those questions at the end of all the presentations. And you can type the question and specify the speaker to whom you are addressing the question. And then at the end, there will also be a quick Zoom poll regarding your experience with this webinar. So let me take this opportunity to introduce our first speaker, Dr. Kim Lindblad. She's a malaria epidemiologist with over 25 years of experience, and she previously served as PMI Insights Technical Director and Senior Technical Advisor at PATH, and also led the Malaria Elimination Unit at World Health Organization's Global Malaria Program. And her work has greatly supported national programs and global partners across Africa, Asia, and Americas, and with a strong focus on operational evidence, policy guidance, especially in the elimination strategies. And Dr. Lindblad will be presenting the findings of systemic review and meta-analysis on MDA used to reduce malaria transmission, and that also supported and informed or contributed to current WHO recommendations for final phase of elimination and prevention of reestablishment of malaria in different countries. Over to you, Dr. Kim.
Thank you so much, Dr. Valecha. I'm going to share my slides. I hope you can all see them. Thank you so much. It's a real honor to be invited to speak on this APMEN Tech Talk. As Dr. Valecha said, I'm going to be reporting the findings from a systematic review and meta-analysis that was used to inform WHO recommendations around mass drug administration for Plasmodium vivax. So first, to start with a little bit of a definition of MDA, which in the WHO lexicon is a full therapeutic course of an antimalarial medicine, irrespective of whether a person has symptoms or is even infected with malaria, to a defined population living in a defined geographical area at approximately the same time and often repeated. Now, it's a very long definition, but the basic idea is that we are targeting a parasite reservoir and attempting to cover that population that forms the reservoir with an effective antimalarial medication in order to clear infections and prevent new infections over a period of time. Now, we have used MDA sometimes in different ways, some of which have meaningful differences from this definition and some of which are very similar. But in a lot of contexts, you'll see the terms focal MDA. And that's generally the term that's used when MDA is deployed in a smaller population. But it's still an MDA. It's still attempting to cover a parasite reservoir, just sometimes in a more isolated or smaller area. Now, there's also this term called reactive drug administration, which is a similar idea to an MDA, but rather than targeting a geographic area, you are targeting the population living around a confirmed malaria case. And the effect may not be quite as the same as a full MDA because you may not actually be covering the entirety of a parasite reservoir. And then finally, I think it's important, particularly when we start talking about Plasmodium vivax, to clarify another type of mass drug administration that's using only primaquine. Now, WHO doesn't term this as a mass drug administration. It's referred to as a mass relapse prevention when only primaquine is provided to a population in an area with Plasmodium vivax transmission. And that's because it's not truly a full therapeutic course. It would not affect necessarily the blood stage parasites. Now, previously to 2020, WHO only had recommendations around mass drug administration for Plasmodium falciparum. And so in the early 2020s, when we were looking at improving recommendations to national malaria programs on how to eliminate Plasmodium vivax infection, we commissioned a systematic review to look at the evidence on the use of MDA for Plasmodium vivax in two contexts. One in the final phase of elimination, and the second as a burden reduction, the use of MDA as a form of chemoprevention. Now, today I'm really just going to be talking about the former, that is the use of MDA for the final stages of elimination. It's important to understand a little bit about the WHO guideline process. The first step after commissioning the systematic review is to develop what's called the PICO question, and that is the population, the intervention, the comparator, and the outcomes. And this is a guide for the systematic review process. It allows those that are conducting the review to know what kinds of articles, what kinds of studies will be entered into the review process by defining, are we talking about the whole population? Are we talking about specific demographic groups? How exactly do we define the intervention? We can expand the intervention to be a little broader, or we can make it very narrow. Who are we? What kind of comparator do we want? In some cases, this might be a placebo-controlled comparator. Sometimes it may just be a community that does not receive the intervention. And then what are our outcomes? We're looking at parasite incidence. We're looking at clinical malaria. Are we looking at parasite prevalence? Are we looking at safety data? So those have to be defined first. And then that is given over to the systematic review team, who have to define the inclusion and exclusion criteria for studies. Now, in the past, we've often emphasized the importance of cluster randomized controlled trials when we're talking about interventions that are applied at the community level. But it's also possible in the WHO process to include non-randomized studies. So before and after studies that are controlled, step wedge trials, etc., other kinds of study designs that might not be the exactly equivalent of a randomized cluster trial. The systematic review team assesses the level of bias in each study, and it's clear that a non-randomized study is generally going to have a higher level of bias. That means that the conclusions we draw from it are less certain than a well-conducted cluster randomized control trial, but they can still add important information to the guideline process. WHO assembles what's called a guideline development group, a GDG, which consists of experts and interest holders. And then they take the results of the systematic review, examine it carefully, and add in considerations for other contextual issues that may affect whether or not WHO is going to recommend an intervention. And then they come up with their final conclusions and then present that sort of discussion and thought process in Magic App, which is a web-based guideline that allows you to really follow the whole thinking and the evidence that's available to support a WHO guideline. So those of you who are very familiar with MDA for Plasmodium vivax will not be surprised that the systematic review, which was conducted back in 2021, did not find that many studies. In fact, we found only 12 studies that were conducted in areas with Plasmodium vivax. Now, many of them were from your region in the Asia Pacific, but there were some countries that were found also in Central America and even in India and South America. So we had some randomized controlled trials, all of which were conducted in the Asia Pacific region and conducted relatively recently from 2019 to 2021. And then we had a group of non-randomized studies, most of which were uncontrolled before and after studies, and they occurred over a much longer period, even as far back as 1936. Now, in the randomized control trials, most of those were using dihydroartemisinin and piperacin, or DP, sometimes DP plus single low-dose primaquine, and those studies either had one single round of MDA or had 3 monthly rounds. In those non-randomized studies, they had a broad mixture of different kinds of antimalarials, but it's important to note that none of them used an artemisinin-based combination therapy. And only one of those trials, and in fact, only one out of the 12 studies, actually included primaquine for radical cure. So the risk of bias summary that was conducted for these studies showed that the randomized control trials generally had a low risk of bias. There were some problems with inconsistencies in baseline malaria risk and low numbers of clusters included in these studies. And at least one of the study had some concerns about potential contamination because their different clusters were very close to each other, and it's possible that they had people moving from one cluster to another. The non-randomized studies generally showed a high risk of bias, meaning that we're less certain about their findings. Sometimes their eligibility criteria were unclear. They didn't always provide all the information that was needed in order to evaluate the study. Some of them were using their outcomes measured through passive surveillance, and there was the possibility that the knowledge of MDA in those communities may have affected their healthcare seeking behavior. And they generally had some difficulties controlling confounding. When we looked at safety data, there was generally a low risk of bias with most of the information on the safety of MDA. Oops, sorry about that. Now, I'm not going to present too many of these graphs, just some of the key ones from the publication, which you can access at any time. So here are two of the forest plots that came from the studies that looked at Plasmodium vivax prevalence 1 to 3 months after the last round of MDA. And among the cluster randomized control trials, you can see that the meta-analysis showed a substantial reduction in Plasmodium vivax. Now, it's important to note that most of these trials were conducted in order to reduce transmission of Plasmodium falciparum. They were not designed specifically for Plasmodium vivax, but you can still see that within 1 to 3 months after the last MDA, there was an 85% reduction overall in the prevalence of Plasmodium vivax among the cluster randomized control trials. A similar reduction was found in those older trials that were not randomized, but they also showed a more than 80% reduction in the prevalence of Plasmodium vivax 1 to 3 months after MDA. Now, when you start to move out farther away from the last MDA round, you start to see that the impact of MDA dissipates. So in the cluster randomized control trials, between 4 and 12 months after the last round of MDA, there was no difference in the groups that received MDA and the groups that didn't with respect to Plasmodium vivax prevalence. Now, in those older non-randomized studies, there was an impact, but again, the confidence in this reduction of 60%, which is basically only based on a single study, is not very high. Let's look at the incidence of P. vivax clinical disease, again, 4 to 12 months later. And we can see that there was some unexplained findings that actually in the cluster randomized control trials, there was a 38% increase, but almost not significant in the incidence of P. vivax clinical disease 4 to 12 months later, and a slight reduction in the non-randomized trials. But these studies suffer from, not necessarily suffer, but these studies have differences in the way that they measure the incidence of P. vivax clinical disease. So that's just to give you an overall picture of the findings that in essence, there was relatively robust findings of an impact on Plasmodium vivax prevalence within 1 to 3 months after MDA, but not so much of an evidence of a longer term impact. None of those studies used a full course of primaquine. Now, it's important in the WHO recommendation process to not look only at the evidence of impact, but to consider the other factors that are very important in order to roll out an intervention, such as what was the population acceptability of the MDA? And in general, reviewing the studies that reported on this, most of the studies showed that there was a high level of acceptability among the community. They felt that there was both a personal health benefit, but also understood that there was a community benefit from undertaking MDA. But there was a concern about adverse events. And in particular, a lot of the adults were concerned that adverse events from the MDA could impact their ability to earn a living. In terms of the feasibility of implementing, of course, you can all imagine that in remote areas or with mobile populations, it's very challenging to implement a mass drug administration. And one of the important issues is whether the population is going to be present during your MDA. A lot of mobility in a community means that many people will be gone during the period that the MDA is implemented. And that means that not only are they likely potentially to return back to their communities with parasites, but they also don't receive that period during which they are protected from infections. And then in terms of finances, there was a wide range of costs of these MDAs. Medication accounts up to 70% of the cost of implementing an MDA. And of course, as you increase the number of rounds, which is likely to improve the effectiveness of the implementation, your costs are also going to increase. So in the end, after the WHO guideline development group reviewed all of this evidence, both from the forest plots on the impact as well as the contextual evidence, there was a decision to provide a conditional recommendation for MDA to reduce transmission of Plasmodium vivax, but with very low certainty evidence. And so WHO does say that in areas with P. vivax transmission, countries can consider using anti-malarial medicine as chemoprevention through mass drug administration, but to recognize that this effect may wane within 1 to 3 months, that they should consider the kind of area where they're going to apply the MDA and ensure that there's not significant mobility in that area, that people are relatively staying put, that they should ensure that they're not diverting resources to implement an MDA that would be better used in implementing case management or good vector control. And that if you are considering using primaquine to prevent relapses, that decision be taken very carefully to ensure that it's safe and feasible to implement what is a much longer course of medicine. I just wanted to take a moment to consider how these WHO recommendations can be strengthened in future to have a potentially stronger recommendation. So in general, conducting a cluster randomized trial, which is the least prone to bias, is more likely to be able to strengthen a WHO recommendation. But in many places, a CRCT is not possible due to financial considerations, due to the amount of time it requires, but increasingly because we can't find enough communities in order to apply the MDA to have a robust finding. So in the case where we can't do a CRCT, there are a few things, some of which are very easy, that can ensure that information is incorporated into WHO recommendations. The first is to find a suitable counterfactual or a suitable control community. And there are ways to do that to try and minimize the risk of bias between that counterfactual and what's being the area where the intervention is being implemented. But it's also very easy to improve reporting transparency. A lot of the studies couldn't be evaluated because the information needed to evaluate the risk of bias wasn't included in the report. So using some of these checklists like STROBE is a way to make sure that your report that's being published includes all the information that WHO would need. And that also includes registering even non-randomized studies online and in the various portals that are available for that, and including a statistical analysis plan in advance will strengthen the results that come out of a study. But also managing confounding in non-randomized studies is very important to make sure that that the results are not confounded by some third variable. So I'm going to stop here. I'd just like to acknowledge the co-authors on this systematic review and meta-analysis, as well as the WHO Guideline Development Group for all of their work in reviewing this evidence, and the WHO Malaria Elimination Steering Group that helped us to get through the process. So thank you very much, Nina.
Thank you, Kim. For the deep dive into dynamics of WHO recommendations, and I have been part of the same, and I know how the evidence is dealt with, and also the guidance on how to strengthen the inputs for these recommendations by, what type of studies could be more useful. But all said and done, especially for Vivax, malaria, and MDA, there are so many things which one needs to consider. First of all, being conditional. The countries have to think that how they can manage, because where to target these, how, and other issues related to that, and also the coverage. Those aspects you have covered, but if we have the questions on that aspect, especially from National Malaria Program, I'm sure we can address those and discuss. Thank you once again, Kim.
Thank you.
So now we move to our next speaker, Dr. Soy. And Dr. Soy is a public health professional with over 20 years of experience in disease prevention. And he's executive director of the Center for Health and Social Development, and has led large-scale programs on malaria, TB, HIV, and other communicable diseases in Cambodia and also in the region. And he's currently principal investigator of a study on operational feasibility and costing of MDA and PV Serotat for Vivax malaria elimination in Cambodia. And now today, Dr. Soy will be sharing his experience from recently conducted MDA with chloroquine as a public health approach for Vivax malaria elimination in some provinces. And also he will reflect on requirements of a successful MDA intervention and discuss his views on how MDA can shape the malaria elimination policy and implementation, especially in Cambodia. Over to you, Dr. Soy.
Thank you. Thank you very much, Ina. Good morning, good afternoon, good evening, wherever you are. You hear me?
Yes, we can hear you, Dr. Soy.
Okay.
Yeah, we can. Yes.
Thank you. So in the next 15 minutes or so, I will walk through with you the operational feasibility and the costing of MDA. And in this study, we also have the PV serological testing and treatment in Cambodia. I represent the group actually to present this. As you know, Cambodia reached 0 local case by the end of 2025. the January 2026, only 1 case for the whole country. PV is the predominant malaria species from 2017. Cambodia has relatively high prevalence of G6PD deficiency from 2% to 20%. It varies from the west to the east of the country. FDA has previously been deployed as strategy for PF, Plasmodium falciparum, malaria control in Cambodia. MDA and PV serotat are indeed a new approach in the country. The program and partner pilot this initiative to assess their operational feasibility and cost effectiveness. 4 rounds of MDA chloroquine to reduce the Plasmodium Vivax malaria transmission in the Cambodian highest burden of malaria district. The study finding could greatly influence malaria elimination strategy by providing a more effective and efficient approach in reducing the burden of malaria PV, ultimately support Cambodia achieving the malaria elimination goal. MDA for Vivax has not been carried out in Cambodia. As Kim just presented in her meta-analysis, and actually it's conditional recommended by the World Health Organization, and the cost, as mentioned in the previous speaker, vary from $1 to almost $20 per person per round. Actually, the cost, it depends on the drug price and the delivery mechanism. However, little is known about the cost to the Cambodian public health system for using MDA as effective tool for PV elimination. National program recognize that MDA with CQ chloroquine alone may not address potential hematozoa reservoir, while the MDA radical cure is not ideal due to safety concern, as mentioned also previously. What are the objectives of this effort? The main objective to undertake an observational prospective cohort study to determine the operational feasibility, costing, and acceptability of the approach. Primary objective to determine the operational feasibility of 4 rounds using chloroquine as a blood stage treatment. Secondary objective to evaluate the cost, to explore indeed the community healthcare worker, policymaker acceptability and the perception of the approach mentioned. Anticipated exploratory objective to assess the effectiveness of MDA with chloroquine 4 rounds, as mentioned, in reducing clinical Vivax malaria cases in the community, and of course, looking at the safety. Where are we doing this? The study site is in the northeastern part of the country, border with Laos and Vietnam. Key activity, MDA 4 round, chloroquine targeting 9 military sites and 6 civilian sites. And the MDA started late March 2025 among military, and then late May among civilian. And then the national campaign in that area went on board. I will show you the timeline of that. And in addition to that, we look also the cost analysis and in-depth interview to assess the acceptability and the feasibility of the interventions. The square is the military size, and the circle is the village of the study. This is the map of Stintrai, the target of the study. The implementation of that achievement among the 2 target population, military and civilian, we got the total first round was 4,443. Of them, 3,100 is among military. And you see that over the course of 4 rounds, we reach out by the end of round 4, 4,333. And of them is 2,997 is among military. So this is the detail among the military, 9 sites of the study. You see the coverage of the study. In addition to the distribution of the chloroquine, 4 rounds, we also follow up in terms of adverse event. So in round 1, we look at, we follow up on day 1, day 2, and day 3. And then across the 4 rounds, and we see that there are some minor side effect or adverse event call, but none of them has been referred to the next level for case management. And the side effect that we encountered was that the nausea, vertigo, and the feel tired. I just want to let you know that the training conducted among military was in March 27 to 28, and then right after that, on 29, we start the first dose of the MDA among them. The same target population now go to the civilian. As mentioned, 6 sides of the study. Of course, we also have the annex of village in there. We follow up the same procedure in terms of side effect of them. Among these 1,336 of them, we follow them up across from round 1 to round 4. And the training was conducted on 22nd to 23rd of April. And then the first case started, MDA was 27 May. This is the timeline of our effort, implementation of this MDA in the northeastern part of the country. We start early 2025, and then March. This is the military, and military start at March and then end in July. While in the civilian, we start 2 villages in May, and then June and July, 4 villages. And then the end of the 4 round was in October last year. And then the campaign by the program was started in September. This is a very high coverage of the campaign. Co-analysis and qualitative assessment. Among the 2 groups, as mentioned, those who reached at round 4, it was 69% among military and 100% among civilian. The cost category, the cost breakdown by stage. We have preparation stage, kick-off, orientation, community census, engagement of community, training conducted, and then the implementation of CQ distribution round 1, 2, 3, and 4, and then 6-month follow-up afterward. The cost per participant reached at round 4 among military was 17.6, and then among civilian almost $20. This is the US dollars. And then we break down by category. Most of the costs go to travel costs, 41%, and then equipment, material, medicine, 26%, personnel costs, 18%, and then other administrative, roughly 15%. Looking at acceptability, 3 groups have been assessed: the policymaker, leaders, implementers, and community. In regard to policymaker and leaders, effective engagement among national program, provincial and the district partner, volunteer, and local authority lead to better outcomes. Trust and understanding were key factors for acceptability. Operational, the motivating factors, direct drug provision, education, and collaboration among influential community members enhance acceptability. In regard to implementer, active participation by community and local authority reflecting their acceptability. Most participants believe mass drug administration contribute to malaria elimination. However, the drug hesitancy mainly among elderly, chronically ill individual, and those with limited social knowledge, leading to rejection. Hard to access, hard to reach to some areas due to rainy season. This study starts perfectly during the rainy season. In regard to community, high acceptance indeed to the chloroquine. And the high willingness participate in the, from round 1 to round 4, but we need time to talk to them, to ensure, provide counseling, to ensure that they understand if they start round 1, they have to complete till round 4. Motivating factor, fear of malaria, prevention, of course, and elimination goal, trust in health staff, enhanced acceptability. More participants were informed well in advance about the MDA. We are facing some side effects as mentioned in the previous speaker, and then mobility and conflicting schedule with their social activity. Generally high acceptability thanks to the operational and the social motivating factors. In regard to feasibility, two groups that has been accessed, policymaker and implementer. In regard to policymaker, strong and well-established primary health care with well-integrated malaria program in Cambodia. High policy commitment in malaria elimination and MDA, active participation by the stakeholder. We are facing some challenges in terms of remoteness, difficult to access to military camp because security and confidentiality, and drug hesitancy, population mobility, and limited stakeholder coordination. For implementers, strong technical support from the national program, provincial and the district level, and of course the project. Necessarily training material are well provided. Active participation by local authority and community. However, we encounter the overburden of some staff, training insufficient in some area, and then delays in terms of supply. Here, it is feasible indeed, with some structure and operational challenges. Overall challenge, as mentioned from previous speaker, the civilian absenteeism as rainy season, a lot of mobility there. And accessibility should lead to change the plan because of the poor road condition and so on. Competing priority is one also of the challenge among care providers and community members. Refusal from some community member to participate in full course because from full course from round 1 to round 4 of MDA due to conflict schedule with their social activity. Next step, continue to monitor and follow up side effect, disseminate result of the study and make use of the finding to support the scale up. I think that my presentation. So thank you so much.
Thank you, Dr. Choi, for a really comprehensive description of the study which was done and the technical depth you brought to this session. And I could see a lot of questions in chat and Q&A which we'll take up later, and you can also have a look on those, especially related to these studies and MDA overall. So now let's go to our next speaker, Dr. Ong. And Dr. Ong Phayo is a senior researcher at Shokolo Malaria Research Unit and has worked with Mydol Oxford Tropical Medicine Research Unit, MORU, network since 2005. And he has led a number of clinical trials and operational research studies along Thailand-Myanmar border, including phase 2 and phase 3 anti-malarial drug trials, drug efficacy studies, and MDA programs, which supporting the malaria elimination. And his current work includes the Vivax elimination with tefnoquine VET study, which evaluates the safety and feasibility of tefnoquine-based MDA in remote and conflict-affected settings. Dr. Fayo today will provide a brief overview of the recent MDA with tefnoquine conducted in Karen State, Myanmar. He will also share the findings and reflect the safety and feasibility of using tefnoquine in MDA settings. Over to you, Doctor.
Thank you, Dr. Nina, for the kind introduction. Yes, I'm Dr. Ongipyo, and I work in Shuklu Malaria Research Unit along the Thai and Myanmar border. And I would like to share the preliminary analysis finding on our work on the safety and feasibility of high-dose tefnoquine-based mass drug administration along the three border village. Yeah. So as you all know that the countries in the Asia Pacific regions, we all target for the malaria elimination by 2030, including Thailand, where the cases are dramatically reduced consistently for 20 years. And for the Plasmodium virus, it globally accounts for around 4 million cases annually, and Asia Pacific got the significant burden. And we have previously proven that elimination of Plasmodium falciparum is feasible, but Plasmodium virus is quite stubborn and it's really difficult to eliminate. And in the graph below, you can see the incidence of Plasmodium vivax and falciparum. Plasmodium vivax in the red line and the Plasmodium falciparum in the blue line. So you can clearly see that around 2018, 2019, we almost eliminated the Plasmodium falciparum and the Vivax as well. We could bring down to very low level. But after the COVID pandemic lockdown and the military coup in Myanmar, the cases were resurging, especially for the Vivax, starting from 2022. And in terms of the number of cases, in 2024, we have over 30,000 virus cases just along the border. So this graph came out from the weekly malaria report from the malaria post on the right side of the graph. So on the right side of the graph, you can see where we work. So this is the Thailand-Myanmar border, and we based here, this is Mesot, and the green dots represent the malaria post, where the malaria post workers are working in their village. So we have over 700 malaria posts along the Thailand-Myanmar border in Karen State. And the red cross shows our TB clinic, and the green cross shows our primary health care clinic along the border. So this is where we work. And regarding the virus, we do have a really difficult sticky problem because it's a major species outside Africa and it's a mother form, but really hard to eliminate because of the relapsing nature of the infection due to the hidden hypnozoite in the liver and the compliance and the adherence problem using the radical treatment, which is primaquine or tefnoquine. And that's why the dormant hypnozoites, they can escape from the diagnosis and they could reactivate weeks or months later. And according to one of the research, it shows that 80% of the recurrent virus infections are due to the relapse from the liver stage. So radical means killing both blood stage as well as the liver stage. But again, the hypnozoites are kind of undetectable. So the mass drug administration Choosing the eradicated cure treatment is a possibility for elimination, but it may be a high risk strategy. So, regarding while we are talking about the virus, um, the glucose 6-phosphate dehydrogenase deficiency, which is an enzyme which helps to maintain the balance between the human red cells and the response to the oxidative stress. So the people with the GCPD deficiency, the hereditary enzyme disorder, when they are exposed to the certain stress factors such as the medication, the primaquine or the tefnoquine, they could lead to the hemolysis. So in this border area, the population has the GCPD enzyme deficiency around 50% of the population. So it's quite difficult for us to provide the radical cure regimen either with primaquine or the tefnoquine. So the tefnoquine, which is a kind of alternative to the potentate primaquine, and the advantage is that it's a single dose regimen, and it could improve a lot on the adherence of the management of the clinical management. And again, the tefnoquine-based method administration hasn't been tested in the real world setting. And in order to use the tefnoquine, the WHO recommendation is that the recipient or the participant should have the GCPD enzyme activity more than 70%. And the contraindication includes the pregnancy, lactating mother, GCPD deficiency, psychiatric disorder, etc. And again, there's no programmatic guideline for for those ineligible people who cannot receive the MDA using the radical cure treatment. So our research question for this study is that can we use it's a kind of a pilot study. So the question is whether we can use the tefnoquine based MDA using the quantitative GCPD testing feasibly and safely in this setting. And the secondary research question is how we should manage the population who are not eligible to the tefnoquine, such as the GCPD deficient people and also the pregnant mother. So the candidate drug tefnoquine, which has a broad spectrum, not only for the hypnozoid, but also it has some activities against the blood stage cytones and gametocyte for falciparum and perhaps the virus. And one of the exploratory objectives is to explore the blood cytonocidal activity or the blood stage activity of the tefnoquine by comparing the submicroscopic parasite prevalence before and after the mass drug administration. We put this as an exploratory objective because in the earlier research with the tefnoquine, it shows that tefnoquine could be used to kill the blood stage 5S as well as the falciparum. So we'd like to know whether the tefnoquine can clear the low parasitemia or the submicroscopic parasitemia. So we received the ethics approval from the Austrac and the local ethics approval. And when we discussed with the community advisory board, they did aware the researching malaria in the context, and all the members they expressed the awareness and they give the positive feedback to the MDA. So we start with the community engagement. So actually, this community in 3 villages, they are already familiar with the master administration because around 10 years ago, we performed the MDA for the Desmodium falciparum. So they are not strangers to the MDA. So this is one of the our community engagement activity. And so in terms of the study village selection, in the map on the right side, you can see the number of virus cases in the villages along the Thailand-Myanmar border in 2024. So we choose 3 villages which are in really close proximity and also close to the border, so that in any case of serious adverse events, we can refer the patient to the hospital in Thailand. And also in terms of the number of cases or the incidents, the median incidence is between 8.2 to 67 per thousand person year. So this is one of our mass drug administration sites in the village. So this study is a single arm pilot MDA study, and the eligibility criteria is non-pregnant, non-lactating, and the age over 6 months with the disability activity of more than or equal to 6.1, which is 70% of the population median, and the hemoglobin value more than 8. So we treated them with the tefenoquine 7.5 milligram per kilogram. And for the village residents who are not eligible to tefenoquine, we provide the chloroquine prophylaxis, either monthly or weekly for total 3 months. So the primary endpoint of the study is the feasibility. So we look for the coverage, adherence, and acceptance, and the safety. So we look for the adverse events, serious adverse events, and the change in the hemoglobin from the baseline. And the secondary endpoints include the virus change in the virus prevalence by the microscopy, and look at the um, prevalence by the RNA PCR at the baseline and the month 1. And we also look at the virus incidence by the rapid diagnostic test through the passive surveillance system through the malaria post at month 3, month 6, and month 12. So we started the MDA between February to April as intensive phase, and we follow up for 1 month for the adverse events. And we also collect the incidence data for 6 months from the malaria post setup. So we screen all the participants for the pregnancy, CCBD activity using the quantitative CCBD biosensor and the hemoglobin level. And also we screen the malaria using the rapid diagnostic test, microscopy, and the PCR. And for the participant positive to the rapid diagnostic test or the microscopy, they were treated using the standard anti-malaria therapy. So the exclusion criteria include pregnancy, age under 6 months, and the known hypersensitivity and severe acute illness such as severe anemia, hemoglobin less than 8. So as I mentioned before, the tefenoquine MDA, there was some concern about it, safety concern about it. So to minimize the risk to the participants and to ensure all the adverse events are properly managed and promptly and timely. So the medical team led by our medical doctor were present and standby at each village 24/7 during the MDA period until the 1 month follow-up. So we measure the hemoglobin level from day 0 until day 7 after the matrix administration. We also look for the met hemoglobin level and also manage for any medical complaints. And before starting the MDA, during the community engagement, we explain the possible side effects of the drug and to come back to the MDA center if they suffer any adverse event. And we set up the referral system if any emergency or the serious adverse events happen, so we can refer to the either of the SMRU clinics or the Thai hospital. So this is the baseline demographic of 3 villages. So I won't go to each and every detail. So the total population is around 1,500, and the MDA participation was around 1,240, which is around 80%. And the first 2 villages, the participation were quite high, over 90%, but the third village participation was only around 72%. And when we look at the ineligibility to tefenoquine, around 29%, which is like 300, over 360 participants, they are not eligible to tefloquine, mainly because of the GCPD deficiency, which is 26%, and the pregnancy. And the baseline microscopy result shows that the plasmodium virus prevalence is around 11%. So we provide the chloroquine prophylaxis for those people who are not eligible to tefloquine. So this is the baseline demographic. And this is the distribution of the GCPD activity of the participant by sex. So as we expected, the, the distribution of the GCPD activity is quite continuous in female and sort of the bimodal in male. And there are around 26% of the participants are not eligible to the tefloquine because of the GCPD value less than 6.1, which is to the left side of the red line. So in terms of the preliminary result, when we look at the hemoglobin change, so we don't see any significant hemoglobin drop between the participants who received tefloquine and who received chloroquine. So there's no statistically or clinically meaningful difference between the two groups. And another perspective of the safety is the looking at the serious adverse events and the adverse events. So throughout the mass drug administration campaign, there was no blood transfusion cases related to the hemolysis. Um, and again, we we experienced 6 cases of the serious adverse events, but all of them are not related to the study drug, such as the severe acute asthma, typhoid fever, or the viral illness. And around 20% of the chloroquine recipients, they got the chloroquine related dizziness. And during the MDA, we faced with 2 deaths, which are not related to the study drug. One with suspected hepatocellular carcinoma with a high alpha fetoprotein, and the other one, the girl with the acute lymphocytic leukemia. And we got one participant who got pregnant at the month 1 follow-up. So we closely follow up that case, and she delivered the baby on the November 25th without 2025 without congenital abnormalities or any complication. So we continued to follow up the baby until the 1 year of age. So in terms of the methemoglobin, which is a kind of proxy indicator for the bioavailability of the tefloquine, so we found that the tefloquine recipients who had significantly higher methemoglobin level compared to the chloroquine recipients. So this is the plasmodium virus incidence per 1,000 population detected by the rapid diagnostic test. So these 3 bars represents the 3 villages. So I have compiled the graph starting from January 2023. So you can see the seasonality in the graph, and we start our master administration in February 2025. So here we started the MDA, and then after a month, we we see that there was almost no cases, just 1 case of virus. However, the incidence rebound after a few months. So which could be due to the armed conflict or the population displacement due to the armed conflict or perhaps the inadequate rounds of the MDA. So we are waiting for the PCR result to evaluate the impact of tefloquine on the submicroscopic parasitemia. And the graph below shows that compares that The incidence of Plasmodium vivax in three groups. The brown color bar chart represents the people who received the Tefnogen MDA. The green represents the people who received the chloroquine prophylaxis, and the gray color represents non-participants. So we found that the incidence of the 5X in the population who received either tefloquine or the chloroquine is lower than the non-participants. However, the difference is not obvious after 3 to 6 months. So, our tefloquine-based MDA is safe and acceptable and sort of feasible in the remote community setting. And our preliminary data shows the reduction of the incidence at month 1, but the effect was quite transient. So we are waiting for the molecular results, and we may need the longer term follow up to clarify the full impact. And, and the key question to address is the question on how to manage those populations who are individuals who are not eligible to 8-aminoquinoline. Yeah, this is the end of my slides, and I would like to thanks to APMEN and all the collaborators and also the communities in the current state. Thank you very much.
Thank you, Dr. Fayal. And I mean, it has been really good information from this particular study, and I'm sure we'll have discussion on all these three presentations now. My first question is, I mean, of course, I have noted down questions from the chat and Q&A box, and some of them have been answered. But Kim, I would like to raise one question because you have been, a part of these guidelines and the WHO guidance. Now, see, basically, as I mentioned, when we talk about MDA, not only Vivax but MDA as such, I mean, there are so many things which are mentioned. First of all, as we say, it has to be targeted, and then it has to be accompanied by other same factors like good surveillance, vector control, and also the area should be either this is a pre-elimination or near elimination setting, and there should be minimal input. I mean, the migrant should not, the issue of migrant should not be there. And also we do mention then in outbreaks and in emergency. So I mean, sometimes it may become confusing for national malaria programs on how to be sure that which is the area where the MDA should be used, because it is not a very, I mean, of course, there is a lot of cost involved as well. And also the other point is that wherever MDA studies, or whether it is pilot or others, even in India, we have seen that their short-term effect, of course, is there. And then we see after some time, if it doesn't come to zero cases in that area, I mean, sometimes the effect of MDA is gone and we again see the resurgence. So how should the country's decision and guidance on this? And in addition, there is another aspect, let me add that so that you can say, explain in one go, the issue of drug pressure and ultimately resistance. So how do we address that and based on your experience from guidelines and WHO? Over to you, Kim.
Thanks, Nina. That was a lot. Let me see. First of all, I think we all recognize now that MDA is not a silver bullet. MDA is not going to eliminate malaria from a country. It's another tool in our toolbox that should be pulled out under the right conditions. But all programs, and I think everyone knows this very well, they need to be running a very solid core malaria program in their areas. They need to have case management operating optimally so that everyone who has a suspected case of malaria is tested, pair it with a parasitological test, either microscopy or rapid diagnostic test, and then is treated immediately with an appropriate anti-malarial medicine. And in the case of a P. vivax infection, that they receive treatment for potential liver stage parasites as well. On top of that, we need to have a robust vector control program. And in some cases, parts of Africa in particular, there needs to be additional chemoprevention to reduce burden. Now, when those things are already working well, and yet we're seeing that in some places we're not getting the reduction in transmission that we think we should, then it is possible to consider these additional interventions, such as mass drug administration, targeted drug administration, reactive drug administration. But all of those additional factors about the location, about the mobility of the population, about the feasibility of delivering the intervention, that needs to come into play. We talk about malaria being a local problem that has to be solved locally. And of course, all of the malaria program staff who are on the ground, they're going to understand the context much better than anyone else, and to understand whether a time-limited mass drug administration or reactive drug administration is likely to be effective in that area. There still needs to be consideration for what comes after that, because under almost no situations, aside from a few very one-off island situations, MDA has never eliminated malaria completely. So the country has to be prepared with what comes next. And usually we think of MDA as being something that can bring transmission down to the point that all of our very intensive surveillance operations can get underway. That's where you start investigating every case with a full workup of where that case was likely infected and where we might be falling short in some of our core programs. So MDA, I think, has its place, but we should consider it as just one among many tools and not always the best tool given the circumstances. Just briefly on the question of resistance, I think that's a question that many viewers brought up. So MDA is sort of a two-edged sword when it comes to resistance. If it's not done well, it has the potential to increase drug selection pressure and perhaps lead to a rise in anti-malarial resistance. Now, we haven't really seen that in many places, but it's definitely a possibility. On the other hand, if MDA is done very well, then essentially it can decrease resistance by essentially eliminating the parasite reservoir. Now, WHO recommends that countries do not use their first-line anti-malarial therapy in an MDA to protect that drug from drug resistance. So that's the first important aspect, is that we should not be using first-line treatment in any kind of an MDA program. Don't do the MDA if you don't think you can achieve high coverage, because that could lead to the worst outcome. And it should be done, as we mentioned, in places where there are co-interventions in place already to suppress transmission. But I think when it comes to drug resistance, MDA is not our number one problem. Our number one problem is monotherapies, it's substandard drugs, it's patient inadherence, et cetera. So that would not be our number one concern about an MDA. Our number one concern is doing it in the right place and doing it very well. Thank you.
Yeah, thanks. I think that's very important. I mean, there are multiple factors which can cause drug resistance, but if the exact, for MDA, it should not be just to showing your success in a particular area and show that sometimes there is intention to show that cases decreased in particular district or something. That should not be the approach. It has to be really a careful decision or selection of area. And then, of course, maintaining, and then there can be different aspects, which medicines, and then for how many rounds and all that, and how we can monitor after that. Thank you, Kim, for that. So, Dr. Soy, there were many questions on the cost, how the cost for MDA was calculated, and it included what issues, and also I can say 2 or 3 at the same time so that you can respond, and why it was chloroquine used, not ACT. Of course, that depends on the policy and resistance of Vivax parasite to chloroquine in that particular country. But then there was also issue on, like selection in military or civilian groups, and IRB issues, I saw they were answered. And I think let us go for these questions, and then we can come back if we have time to more questions on the aspect. Over to you, Dr.
Okay, thank you so much. And I see overwhelmed by question. I try to respond to that, but may not be all of that. But okay, good that. I just want to highlight a little bit that the history in Cambodia about ACT, because Cambodia is one of the epicenter of drug resistant, ACT resistant almost all the available ACT previously resistant. So when using ACT, we had to be very, very careful in that. And as Dr. Kim mentioned earlier, that if this is still a first line treatment, we have to keep that as long as possible to reserve that medicine for the treatment. For chloroquine with Vivax, we don't have any document, although the drug efficacy study continue and to look at. That's why CNM in their decision, they allowed to use that medicine in this MDA. And now I just want to let you know that Cambodia, they start to replicate already that approach to elsewhere beyond the study site already. And then we hope that they will have a big discussion in terms of nationwide deploy on this MDA with that. In regard to, I think that about the drug choice and then 4 rounds. I see there are some 4 rounds versus something. I already tried to answer that. There's some long discussion about that in terms of is it, 1 round, 2 round, 3 round, 4 round, or 6 round. People seem to say that experts seem to recommend that the more round you give, the chance of decrease the transmission may be high. But we have to be realistic. The more time you provide the mass drug administration, you have to make sure that they adhere in there, because as mentioned earlier, that if you do MDA not good, that means whether you do good or you do harm to the situation. And besides that, I see that any other thing, I didn't catch you all the question. Any other specific beyond that, please? Oh, the cost, right? The cost I already mentioned. They have category cost of that. Starting, if you look at the most cost that's spent for this study is the travel cost. Almost half of the effort, because of the late test accumulation of the cases are really remote, and this is a mountainous area, bad road condition, challenge in terms of reaching out to the population and so on. That's why you have to spend a lot of cost for motorbike with the ox cart, not just one go and reach there. So many approaches to reach the and the question why we select the military, because of the as mentioned in the presentation, also the highest area, the highest group that still remain malaria in last year was among military. So that's why military tackle first, and then surrounding of that military was the community. I stop here, and then if any other thing, please, Nina.
Thank you so much. And in fact, many studies on relapses have been done on military, because sometimes it's easy to get compliance and issues like that. Thank you very much. So coming to the next presentation, Dr. Ong, I mean, even I had that question. I mean, what was the rationale or consideration for selecting higher dose, 7.5 milligram per kg of tefnoquine? And the other is that, especially for tefnoquine and even primaquine, that there are a lot of groups who will be excluded from the study. So if it is MDA and then there is some population which is not getting that treatment, how do we think that will be successful? And overall, I mean, not only for your study, and especially how do you feel that when you were doing this as a mass treatment, especially the safety aspects of tefnoquine, could you handle those? Of course, I saw there were not many issues related to the safety, but then managing doing J6PD and especially selecting, ensuring that patients who are where it is not safe to give, they can be excluded when you are doing MDA, because it is not a truly a clinical trial, but you are giving medicine to a lot of community workers. And also there was a question when, because if tefnoquine is generally given with chloroquine in areas where you don't have chloroquine as first
Yeah.
line. There will be few, of course. So then, how this tefnoquine can be used, or if it
Yeah.
is used? So those questions. I think we are getting short of time, but anyway, these are important things. We please
Yeah.
highlight those.
Yeah. Yes,
Thank you.
thanks, Dr. Nina. Let me share one of my slides regarding the dosing. Just one of the slides, please. Yeah. So regarding the the higher dose of tefnoquine, 7.5 milligram. So we know that in the early trial of the tefnoquine, um, the the higher dose up to 600 milligram is sort of tolerable and is safe. So in terms of the efficacy, the radical efficacy, the individual patient data meta-analysis recently published one has shown that um, the routine 5 milligram per kilogram dose, it could achieve around sort of 90% of the radical efficacy, and while 7.5 milligram per kilogram dose could increase the radical efficacy to 50%. So based on that, we have chosen this 7.5 milligram per kilogram dose. And yeah, and then um, another, I would like to go to another question and about the combination with the chloroquine. There are many countries where they cannot use the chloroquine because of the resistance, and they use the artemisinin combination therapy (ACT) to treat the Vivax. So, in order to combine the ACT and the tefnoquine, the studies are ongoing because one of the study in Indonesia has shown that the dihydroartemisinin piperaquine and the tefnoquine combination doesn't work very well. So we the study is ongoing. We are doing we are looking for the drug interaction between the tefnoquine, dihydroartemisinin piperaquine, as well as the artemether lumefantrine. So the studies are ongoing and almost finished, and we could share the result very soon. So there can be a change in the label to use the tefnoquine together with the ACT. Let's see whether what the study result will give us. And again, in one of the preliminary result from that study has shown that 7.5 milligram per kilogram dose is is safe compared to the 5 milligram per kilogram. So
Yes.
yeah, I think that's all of the questions being addressed. I guess.
Yeah.
Yeah.
Thank you very much. So already we are over time, and anyway, we can. So any if I have missed out any question from, I mean, even Manash, Kerry, or anybody who, if you want to highlight if there is any burning question, otherwise we can proceed. I think most of them are covered, and I have seen or answered in the chat or Q&A. Okay, so I mean, on this topic, although a lot of recommendations or some countries are trying to work on this MD, and there were some, like, only primaquine treatment was also, mass treatment was also being given, which Kim explained, and even the guidelines say that is not the best option. So even when in Vivax malaria, especially, even giving only shazaanticide is medicine is not a good option. So that is why we got I mean, good information, or the results from the studies where both shazaanticidal and anti-relapse treatment has been combined for Vivax MTA. So let's see how the results from other studies also shape up, and then maybe WHO can consider on these further guidelines and guidance. So, in conclusion, this session has highlighted that while MDA can yield a short term, of course, short term significant reduction of Vivax malaria, and in different settings the results may be different, but it cannot be a silver bullet. And of course, the liver stage parasite in Vivax always creates a challenge, and we of whether it is diagnostics or the safety of the present medicines, and also the dosing issues. So everything we will come to know when such more studies are done, like we heard results today. And of course it is a valuable tool, but the effectiveness, as I mentioned, depends on so many other factors: operational issues, cost, and coverage. And then, as the another important thing is that it is, we call it mass drug administration, but always there will be some population which will be has to be excluded from this. So how does that impact the results? And also drug resistance, which is important, and because we should not be using MDA indiscriminately, and because we, of course, we have new tools in the pipeline, but they are not, we don't expect many tools or many medicines very fast. So we have to retain the usefulness of the present medicines. And of course, high coverage and community engagements are challenge, and which some of them have been addressed in, as we heard today, from Cambodia and Thailand. But that is another aspect in this type of intervention. So as ultimately, as we move towards elimination, these interventions have to be tailored to local context. So on behalf of audience, thanks to the speakers, and on behalf of APMEN team also, thanks to the speakers, and I thank our APMEN team also, Dr. Manish, Kerry, and Dr. Phone, who have supported this webinar. And of course, there is a new perspective and this topic, and more work will be done, and that can again be if useful for the treatment guidelines for WHO. Thanks to APMEN team once again for organizing this event, and thanks to one and all once again, and have a good day.
Thank you.
And please answer the questions in the poll, all the participants.
Thank you.